one of the highlights of my career. I've been involved with this organization since its inception, and it's been really nice to see it thrive and grow now under Adrian and Tova, and I really am glad that we're here back here again today. So I'm tasked with sort of giving you a primer on fibrous dysplasia McCune-Albright syndrome, and feel free to interrupt with questions. This is really quite basic, so I'm going to give the first half, and then Ed Shaw is going to follow me, and I'll just jump right in. Okay, so these were the pioneers of fibrous dysplasia. I love this picture of Louis Lichtenstein with his cigarette there, quite the representation of a good doctor. He really looks like a movie star. And so that was Louis Lichtenstein, and he was really the one who coined this term, fibrous dysplasia. He was a pathologist, and he was a bone pathologist specifically. And then there was Donovan McCune, this jolly-looking fellow there. His name was assigned to this, even though he didn't even write a paper on it. This is just an abstract, so he really made out with just doing this one abstract and getting his name assigned to a syndrome. Fuller Albright was a real giant in the field of bone and mineral disorders, and was involved in defining and describing many diseases. He's not so jolly looking, but he had Parkinson's disease and had an early death from that. But anyway, so these are the guys who really coined the terms that we use today, fibrous dysplasia and McCune-Albright syndrome. So McCune-Albright syndrome was originally defined by this triad, cafe-au-lait spots. We don't so often call them cafe-au-lait anymore because they're, depending on the color of your skin, they may not look like cafe-au-lait. But anyway, this is the triad, cafe-au-lait, spots, macules, precocious puberty, and fibrous dysplasia. With time, though, we learned that there was a lot more to that. There's many other endocrine problems. There's problems with the thyroid, with the pituitary, with the adrenals, and with the bones as well, the pancreas and others. And we're really still figuring out all of the things that are involved in McCune-Albright syndrome. And I'll go through most of these sort of a high-level view. There'll be discussion about the specifics later. So this is how we think that McCune-Albright syndrome happens. So early in development, a mistake occurs. A mutation occurs in a stem cell. It's by chance. We don't really know what causes it. It's in this gene called GNAS, and this gene, GNAS, codes for this protein called GS-alpha. So this mistake occurs in one cell somewhere early in development. This cell replicates and propagates and spreads out through the developing organism, and it lands in certain places. And we really think that for the most part, the map of the affected tissues is really established in utero. And then over time, they begin to manifest. And we'll talk later about when and where and how these various features of McCune-Albright syndrome manifest. Okay, so we have this gene, GNAS. It's prone to mistakes, and that's why it gets mutations in there. It's such an important gene that if it occurred in all the cells, it would be lethal. And the only way that someone survives with this is because it only affects some tissues. There's no known environmental, ethnic, or geographic risk factors for the development of this. And so far, all the cases of McCune-Albright syndrome have been sporadic. The disease does not come from the parents, and the parents will not transmit it to their children. I think a good way to think of G-alpha-S is as a sort of master on and off switch. So, and depending on the tissue that it's in, if it's in the skin and it affects the pigment-producing cells, you get these pigmented skin spots. If it's in the ovary, you can get precocious puberty, bone, fibrous dysplasia, etc. And there's other organs as well, the pancreas, the heart, the brain. The manifestations in these other organs are not as well described, but they probably can occur there also. So, as a way of a definition of fibrous dysplasia McCune-Albright syndrome. So fibrous dysplasia is a skeletal disorder that we'll talk about. It's due to this mutation, this gene, and this protein. And McCune-Albright syndrome is fibrous dysplasia plus one other extraskeletal manifestation, at least one or the other. And these can really occur in any combination. I put this up because sometimes there are misdiagnoses, and sometimes the diagnosis can be wrong, and sometimes it can be difficult. If you have, for example, fibrous dysplasia and a cafe-au-lait spot and a hyperfunctioning endocrine problem as part of this, then the diagnosis is easy. You don't need to do any further testing or biopsies or anything like that. It's pretty clear. However, if you get down to fibrous dysplasia and just a cafe-au-lait spot or fibrous dysplasia only, especially in the craniofacial bones, it can be really tricky. And for some of these, you really need to do genetic testing, a biopsy of the tissue and genetic testing. Genetic testing is getting better, and pretty soon we'll be able to do genetic testing in blood, but not there yet. So now, for certain conditions, we do recommend that you get a biopsy to confirm the diagnosis. So really, McCune-Albright syndrome is a subset of fibrous dysplasia. We think that fibrous dysplasia is much more common than McCune-Albright syndrome, and patients with McCune-Albright syndrome are a subset of patients with fibrous dysplasia. The exact numbers of this, the exact prevalence of this really isn't known. It's a question we get asked all the time. It's kind of a shame we don't know, but we don't. Okay, so this is the relative prevalence of these findings in McCune-Albright syndrome, and this is the relative prevalence in the patients that we've seen at the NIH, and we probably have a sort of referral bias where we're really looking for patients with fibrous dysplasia. So almost all the patients that we see have fibrous dysplasia. Most of them have pigmented spots. In terms of involvement of the gonads, whether it's full-blown precocious puberty or just benign tumors in the testicles, for example, in the men, of the patients that we see, about 2/3 of them, three-quarters of them have involvement of the gonads. And I think it's one of the reasons why we recommend that people who have McCune-Albright syndrome, men in particular, get their testicles scanned to see if they have these. There's been one single reported case of a man with testicular cancer as part of McCune-Albright syndrome, but anyway, it's something to look out for. The thyroid is commonly involved, and this phosphate wasting, which I'll talk about more later, is actually to some degree present in about half the patients we see. In many, it's quite mild, and only a subset of those require treatment for it, but it can really make fibrous dysplasia much worse. Growth hormone excess and Cushing's syndrome is probably one of the least common features of it. Okay, so another organ that we've become more aware of in the last 5 years or so of being part of the syndrome is involvement of the GI tract. Patients can have reflux, but most of the country has reflux, so it's hard to know if that's really associated to McCune-Albright syndrome in an individual. But patients can get these small benign tumors, these polyps, pretty much anywhere along the upper part of the GI tract, so in the stomach and in the small bowel. The liver can frequently be involved, and one of the more common presentations is hepatitis in children, young children. It, for the most part, seems to sort of fade away as patients grow, but it can be there. It never seems to, or rarely seems to, cause any significant problems. Involvement of the pancreas is something we've become much more aware of, and I'll talk more about that later. Myxomas is in the muscle, so these are benign tumors within the muscle, and it has another name, Mausebrout syndrome. The heart has been shown to be involved, and this can cause a rapid heart rate in some patients. We also think that the brain is probably called, there can be learning deficits or ADHD-like behavior, but again, these are common findings in the general population, so it's hard to know if they're really related to the disease or not, McCune-Albright syndrome. Okay, so this is a chart that gives the age, the relative age at which features of the common features of McCune-Albright syndrome can occur. This is just a guide, it's not written in stone. And this shows really that if you look out by probably about the age of 10 or so, that pretty much everything will have manifested. You may have to look hard to find it, but probably around the age of 10, things can occur. All the things can occur if you do a careful screening. And the implication of this is that if you do a really careful screening sometime around the age 10 or after, everything that is going to appear will have appeared, and there won't be any surprises later in life. Again, not written in stone, but a good guide. Okay, so a little bit about fibrous dysplasia. So fibrous dysplasia is a disease of the skeletal stem cell. So this is a normal skeletal stem cell, and a normal skeletal stem cell gives us all the cells that are in bone. It gives us the osteoblast, the osteocyte, chondrocyte that makes cartilage, the fat cells in bone, and the cells in the bone marrow that are important for the support of blood formation. If you have this mutation in this skeletal stem cell, this is what we think happens, that you can make bone. There's actually a lot of bone in fibrous dysplasia tissue. It's just bad bone. It's not organized. It doesn't work well. And so you make bone. You can also make cartilage, but you don't make the adipocytes and you don't make the hematopoietic supportive cells. Anyway, so this is how we think that fibrous dysplasia occurs. It starts in the skeletal stem cell. And so this is sort of a cartoon of what a chunk of fibrous dysplasia would look like. So if you take a piece of fibrous dysplasia out of a patient, a young patient in particular, you will find normal cells in there as well. In a young patient, most of the cells will be these abnormal cells, and we think that these abnormal cells have the ability to sort of co-opt the behavior of the normal cells that are there and make them behave like an abnormal cell. What also appears to be the case, though, is that with age and with time, that the mutant cells sort of die out to some degree. They probably exhaust themselves, so that if you took a biopsy from an older patient, you'll have the ratio of normal cells to abnormal cells will be higher. The implications of this aren't entirely clear, but it does give us insight and perhaps a way in which we could, in the future, sort of co-opt this natural phenomenon to develop some sort of treatment with patients with fibrous dysplasia. Which bones are involved? So this is we did a survey of all the patients we had seen at the NIH at one point, and so the bones that are most commonly involved are the skull bones, and in particular the base of the skull. So the skull is most commonly involved. After that, the femurs are the next most common, and after that, the other bones. So very commonly that the skull and the femur and other bones are involved, as shown here. Okay, so age is when and where bone disease occurs and expands. So if you take a young child, 90% of the patients who are going to have fibrous dysplasia in the skull, if you did a really careful look by a CT or a bone scan or something like that, before the age of 5, you'll be able to know whether that or not that kid has fibrous dysplasia. And really, the latest is by the age of 13, which is the appearance of lesions in the long bones. But really, the implication is that almost all clinically significant, so that is involvement of the bone that's going to give you problems, is present at an early age. So again, if you look really closely at an early age, you can figure out what bones are involved, and importantly as well, which bones are not involved. Okay, so I'm going to just quickly go through the sort of segments of the skeleton that can be involved. And the axial skeleton, for example, is like the spine and the pelvis and those bones. And one of the big problems in that is scoliosis. And as you can see here, if untreated and it progresses and it's bad enough, it actually can be lethal. The sort of really good news about scoliosis, and this is actually somewhat of a surprise, is that if you intervene early enough and fix it like is shown here, it's remarkably stable over time, much more stable than the operations on other bones, and it's really quite surprising. So the panel on your left then, that's an MRI of a patient with fibrous dysplasia. As you can see, there's a lot of fibrous dysplasia in her spine. Amazingly, this woman had no pain whatsoever. So it's quite remarkable which bones have pain and which bones don't, and which patients have pain, which patients don't. And I think that Dr. Boyce is going to talk about that later, right? She's probably putting her slides together right now. No, I'm just kidding. Anyway, and so the appendicular skeleton, so this is the long bones, and probably I don't need to tell you guys about this because you know about this. So long bones can be commonly involved. They bow, the second panel, the one that's a shepherd's crook, it's called a shepherd's crook because it looks like the staff that shepherds used to carry. I don't know if they carry this anymore. There's a normal one. And then, of course, as you all know, fibrous dysplasia is not strong bone and is prone to fractures, and this is the bane of the existence and the way that Bob Stanton and Jason Malone make a living. So, now, I did want to talk about the endocrine problems, and this is, again, I think it's important at least once to have pretty much all of the endocrine organs that can be affected tested to see if they are affected, because if they are, they can make the disease worse. And I'll talk a little bit more about the hypophosphatemia, so that's low blood phosphate. That's a particularly problematic feature of this, and it gives you more fractures and fractures earlier if you have the hypophosphatemia. As you can see, it also, hypophosphatemia and hyperthyroidism can also make scoliosis worse. This condition is called basilar invagination. This is when the base of the skull is so soft that it sort of settles down on the spine, and it can cause big problems. And this, again, is made worse in patients who have untreated hyperthyroidism and hypophosphatemia. And finally, growth hormone excess is particularly problematic with patients who have craniofacial fibrous dysplasia. Very important for that to be tested. It can lead to vision loss and hearing loss, which are generally uncommon features of this, but more common if you have untreated growth hormone excess. So, the problem of phosphate wasting. So, patients with fibrous dysplasia make this hormone FGF23 in the fibrous dysplasia bone cells, and this causes you to basically pee out phosphate. So, you eat phosphate, you take phosphate, and it leaks out as you're it's like trying to fill a leaky bucket. Generally, it's only present in patients who have a lot of fibrous dysplasia. So, if you just have a little bit, it would be unlikely that you have it. It makes the bone softer, it leads to bowing, to pain, to fractures, and earlier fractures. This is a cartoon of the fact that this FGF23, this hormone, is made by fibrous dysplasia cell. It acts at the kidney to promote what we call phosphaturia, leaking of phosphate into the urine, and low blood phosphate levels. You need phosphate to make hard bone. Okay. The traditional treatment of this is really kind of a pain in the neck. You have to take medications 3 to 4 times a day. You have to be monitored carefully because they can have a lot of problems. There is a new treatment available, this medication Burosumab. It's called Crysvita. It's made by Ultragenyx, one of the sponsors of this meeting. And there's an ongoing study looking at this at NIH, and Dr. Boyce is the principal investigator of that. And I think she's still looking for patients, yes. Getting near the end now. So anyway, okay. So a little bit about the GI problems that can occur in McCune-Albright syndrome. So probably the most common may be the pancreas. You can get a particular type of pancreas lesion. I'll show you in a minute. The luminal part, which is the esophagus and the stomach, we think it's only the first part of the GI tract. We've not seen involvement, for example, in the colon or in association with colon cancer, that sort of thing. The liver can be pretty commonly involved, and it's especially the liver more common in neonates, as I mentioned earlier. Anyway, so the thing that you can get in the pancreas is this long thing that we'll call IPMNs. And these arise in the ducts of the pancreas. They're actually pretty common, especially more common in older men, so it's not unique to fibrous dysplasia. There's some debate as to whether these IPMNs are sort of a pre-cancerous lesion. It's an open debate within the field of gastroenterology. I think they probably are. I don't think it's a big driver of cancer, but the same mutation that's found in McCune-Albright syndrome is found in pancreatic cancers quite commonly. So it may be a contributor to that. We really don't know if it's if patients with MAS with this are at increased risk, but I think it is important to be screened to see if you have these, and if you have these, it's probably important to be followed, especially until this is settled. Yes, sir.
Yes, my wife spoke to my endocrine consultant in Edinburgh about this. He booked a specialist who said the screening of this is difficult, it's intrusive, it can cause problems in itself, doing the screening, and didn't want to do it.
Well, so actually, that's a good question. It leads right into, I think, the next slide. It does. So the best way to screen for this is with a type of MRI, which is called an MRCP. I think what he was probably referring to, one of the ways that you could screen for this is through a procedure where you go down the GI tract with a scope and a tube and a camera, and it's called an ERCP. I can't remember what ERCP stands for, but it does have associated with it a high complication incidence of actually causing pancreatitis, but you really don't need that for screening. That would be more of a diagnostic if you needed to take a biopsy or something like that. And if you need to have it, you need to have it, you know, if you think there's a cancer there. But, so this is what a normal pancreas looks like on an MRCP. And you can see that skinny little tube that's labeled the pancreatic duct and the common bile duct and the duodenum. This is what a normal pancreas looks like. It's really an incredible procedure that they can see this teeny little pancreatic duct so clearly with an MRCP. And the one on the right, this is a patient with IPMNs. You can see how significantly dilated the pancreatic duct and the common bile duct are. And the reason they're dilated are shown in the two bottom panels. On the left is an MRI and on the right is a CT. And this is a patient who had a lot of these IPMNs in his pancreas. So they were really quite significant. This patient has had these probably for years. They haven't done anything. He's been quite stable. But, if he walked in off the street and didn't have McCune-Albright syndrome, this patient would certainly get this invasive procedure and a biopsy to make sure that these aren't cancers. We think that if we see these in patients with McCune-Albright syndrome, we do serial MRCPs on them. If we see them changing, or if we see them getting larger, if they're obstructing the pancreatic duct, then they need a procedure. But most of the time, they can just be observed. Okay. All right. So the GI, the most common is IPMNs. Patients, some patients can get adenomas, benign tumors within the liver. And we think there's a low risk for pancreatic cancer or liver cancer as well. They occur at a relatively younger age than the general population of patients with McCune-Albright syndrome. And if a patient has a history of having had pancreatitis, then there's a good chance that a patient with McCune-Albright syndrome, a good chance that they have an IPM. And the optimal care for all of these things is evolving at this time. All right, I think that's it. I did want to make an announcement before I step down to everyone that I'm going to be retiring from the NIH sometime next year, in the early part, middle of next year. I'll still remain involved with this organization if you want me. I'm not retiring from life or from science, but I'm just retiring from the NIH. And of course, you all know that you're in fantastic hands with Dr. Boyce there. So she's been leading the program really for at least 5-6 years now anyway. So anyway, that's it. And I think, Ed, we have I'll take a few questions if there's any questions, and then Dr. Shao is going to talk. Yes, ma'am.
So approximately what age, you said young versus old, for the mutant to normal ratio changes in both?
Well, that's a good question. Nobody knows the answer to it. Maybe Mara or Biagio have an idea. The small study that was done that looked at this pretty carefully, it's a continuum, it's a fraction. So, when you're old, you have less. When you're young, you have more. I don't think anyone can really say what. Do you agree with that, Mara, Biagio? Yeah. So,
What about the age for pancreatic screening?
Well, that's a good question. So you do have to get an MRI. So a patient, a kid, has to be able to lay still enough for an MRI. 10.
Yeah, we actually, in the one we talked about is Sunday.
Okay, good.
We haven't recommended that everybody get an LRCP, however, we have recommended with any LRCP dog with a very low nutritional value. Like Dr. Collins said, it does involve fluid still for a decent length of time, so we generally take 8, 9, 10, somewhere in there.
Yeah. I mean, if a younger kid had pancreatitis, which we had one kid who had it, and at the time we didn't know about this, we would have done it then if he was younger than 10. But if you hadn't had any GI problems, you know, I probably recommend that most anyone with significant McCune-Albright syndrome get one.
Thank you.
Okay.